So thanks for having me here to speak to your network meeting. And I know Pat from some work on Protect. So I'm happy to be here to talk a little bit about workplace indoor air quality. But I'm going to talk a little bit beyond that because so I work at the Institute of Occupational Medicine, and as the name implies, we do mostly work around occupational settings. And just as a tie to David Fishwick's presentation earlier, we got our start. We were set up by the National Coal Board to study the impacts of coal dust mining on lung health. And obviously, we are no longer part of the Coal Board. We're an independent charity, and we do research in a number of different areas, not just workplace health, but also as a logical continuation from the work that we've done earlier, we do some work on air pollution as well. So I will talk. My start, however, I was more of an environmental health person. So I got my start more in indoor air quality and personal exposures. So I would like to talk a little bit about workplace exposures, but in the context of kind of our daily life exposures. So as I mentioned before, I originally, and I still, a lot of my work at IOM has focused around personal exposure. But because obviously we do a lot of work at workplaces, I am going to look at kind of how workplace influences that. And we've heard today, and I think most of you probably know that sensors are now kind of a hot topic. And these are, when I say sensors, I mean, obviously there are many instruments out there and they're all kind of sensors in some ways, but we're really looking at lower cost sensors. So things where they're a bit smaller, they're not like your direct reading instruments that cost 10,000 quid from TSI or someplace like that. So that's what we're looking at when that's what I'm referring to when I talk about sensors. And so it's a bit of a continuum. It's how are we using these sensors? So for people who study personal exposures, we're really keen on things that people can carry around with them, but we also want to be able to preserve the kind of the accuracy of the data, or at least understand what the information is giving us. I'm going to talk a little bit of COVID-19 just because that's been so much of my working life in the last couple of years, and it does fit a little bit into this kind of wheel that I put out here. So if I start a little bit talking about air pollution exposures in general, so obviously we spend about 90% of our time indoors. I don't think that's news to any of you here. And I would say that for most of us, work is a big part of everyday lives. It's approximately a third of our working life, and most of us will spend that indoors. So from a perspective of where your exposure is coming from, being at work and being at home are generally the ones that are the areas that we're most interested in. And this is just, I took this from an article on where they've done some measurements of personal exposures, and I like it because it shows how variable your exposure can be. This is PM 2.5 over the course of a day. So each line is a different person, and you can see that during the weekday, your patterns might be different from weekends. In fact, there's a bit more of a distinct pattern on the weekday, a bit lower actually during the work day. And this is probably because I think most of these were office workers. This is just an excerpt from some work that we did in Beijing, and we did some measurements of PM 2.5 and black carbon, which is a component of PM 2.5 that is of some interest from a health perspective. And we did find, again, these are primarily graduate students, but again, as I mentioned before, their home base or the residence and their workplace are really the areas where, in terms of your cumulative exposure, you're getting most of your exposure to air pollution. And this is even if you have much higher concentrations in other, what we would call microenvironments. So I'll talk a little bit about VOC exposures. This is something that, this is, again, I always go back to, where I got my start, and it was really in VOCs. And I think indoors are really important environments for this. Overall, compared to the outdoor environment, for most VOCs, a lot of your health risks are driven by the exposures that occur indoors, but also because of the sources. So usually indoor environments can have much higher levels of certain VOCs than outdoors. And this is usually because, not just because of the building envelope, but also because there tend to be a lot more indoor sources. And workplaces could potentially be large contributors to personal exposure, even in relatively everyday places. And an example I'll give of this is some work that was done, again, this is from my PhD work, and that was many years ago already, but I think it's actually still true today. So this is just an excerpt of a number of VOCs we measured, and we looked at, this was in Massachusetts, so we looked at shops, so stores, and we separated those from supermarkets or grocery stores. We also looked at restaurants and bars that were smoking and non-smoking. So this happened right at the time where they started bringing in regulation for that. And we compared these also with offices. And actually, if you sort of simulate a person's exposure and you assume that, so this is a simulation of, and these are the results of where the proportion of their total exposure that would come from being at work in one of these locations. The dotted line shows, 30% of their exposure, which if you consider that they spend about 30% of their time at work, that's what you might expect. But what you can see is these are box plots, so you see the variability of the potential range of exposure people can get. And they can be quite high, actually, when you look at the time that you might spend at work and the concentrations that you might encounter there. I do want to point out also that here, let's see, the smoking. So something that as a public health intervention has been really great is that you can see that compared to smoking environments, non-smoking areas have much lower levels of exposure. And so in terms of, for people who work in these areas, that's been kind of a great win for their health. So I'm going to now talk a little bit about, so we can see that workplace can potentially be an important place for your exposure and potentially for your health. I want to talk a little bit about an occupational disease research project that we're part of. And this is a European project. So it's a large consortium that's led by TNO in the Netherlands, and it's called EFOR. So it's taking a slightly different view on how we do occupational health research. So to set the stage a little bit, about 4 to 7% of mortality from occupations, deaths, there's about 5 to 7% of mortality can be attributed to occupational disease worldwide. And that would account for about 2 to 6% GDP. This doesn't include, of course, morbidities or sort of injuries or other sort of like living with a disease that you might get from work. So this is potentially something that can be quite large if you think really broadly about how much work can potentially affect us in forms of stress, not just exposure, but stress that you might get from work. And traditionally, occupational epidemiology has taken this one exposure, one health outcome approach. So a very obvious example will be exposure to asbestos and mesothelioma. What we used to do, which is looking at coal dust and black lung disease or coal workers' pneumoconiosis, and we heard about silica earlier on. So this is sort of the approach that works, I think, quite well when you have very high exposures and clear disease outcomes that are related to these exposures. And so this is generally for kind of industrial or more manufacturing-based industries. But because in the UK and in many other countries, middle and high income countries especially, we're transitioning into a very different sort of economy. So a lot of our dirty industries, so to speak, don't happen as much here. And so this approach is maybe not as well suited to the types of occupational risks we might face. So this is kind of this changing world of work. Also, the demographics of who's in work changes. We have a lot of older workers. Many of us will probably work a lot longer than our parents, for example. And so, and the nature of work, we have the gig economy, it's, they're just different types of jobs. So we need to widen this perspective that we use to study occupational health. So one of the approaches that we're looking at is this exposome framework. And this term actually came from more of a cancer researcher came up with this term. And this is really the environmental counterpart to the genome. So the genome is essentially the characterization or the map of all the genes that make you who you are. The exposome would be kind of a map of the environmental exposures that you have that make you who you are. And that, as you can imagine, is a fairly large concept. So I like to say it's something about all your exposures everywhere you go and all your lifetime, because it really does encompass all your environmental exposures throughout your life and even before you're born in some cases. So it's a very broad topic, and as you can imagine, it's a tough one to grapple with because the definition of environment is very broad. It's not just the chemical exposures that we come into contact with, and even within that world, you know, you breathe them in, you ingest them through food and drink, or just, you know, inadvertent ingestion, you contact them through your skins, and different substances have different half-lives. So it's very difficult to characterize. And this is something which, you know, some people debate. We always have this debate, are we going to be able to do it or not? So we're still in those early stages. The other part of the environment I want to bring out that is important is we consider things like social capital, sort of the external stressors that aren't so easily quantified, as something that can still influence your health. And so that's part of the environment. The other thing that we try to look at is how these external stressors, so to speak, interact with the internal environment you have in your body. So an example is sort of these gene environment interactions, which, you know, when we characterize the genome, it turns out that disease causation is only very partially explained by that. Maybe about 30%, less than half of disease is really explained by genes. And so it's really this gene environment interaction, or just kind of this environmental physiological interaction, which we don't know that much about and which we're trying to understand. So how do we do this? I just said it's a very daunting task. Some people look at biomarkers. So, you know, you take a sample of blood and you analyze for all the different kind of exposure chemicals you might have in there. Difficulty with using biomarkers is if you're looking at environmental exposures, you know, depending on the exposure, different matrices may actually be more representative of your real exposure. So there's a temporal aspect that needs to be captured. And I'm not sure we've really come up with a good non-expensive way of doing that so far. But I'm going to talk a little bit more about how we've been taking an approach to assessing external exposures. So we want to measure multiple exposures at once. That's one part of the exposome. But in this project, we really like to understand exposures to the worker in their working life. So not just measuring, as many occupational studies would do, at work, but measuring throughout their whole day, including when they're not at work. And we really want to know, what is that contribution of work to your total exposure, and how might work ultimately affect other aspects of your life, and how might other aspects of your life affect your working aspect, which we know these things are not really hard and fast boundaries. So that's where we'd ultimately like to go. I'm going to focus more on the exposure assessment part of it, just because that's what we've been working on, and the project's really big, so I couldn't cover all of it. But we're looking at measuring many different things, as I mentioned. So we've taken some passive sampling approaches. So passive sampling per se is not a new technology, but we are using like a combined sampler for chemicals that will look at volatile organic compounds as well as semi-volatile organic compounds. And so if you are familiar with this type of sampling, usually you do one or the other. And if anybody's heard of these like silicone wristbands that people have used to measure exposures, it's a similar concept where you're screening for a large number of chemicals. It's just that we've sort of combined a VOC and an SVOC sampler, and one of them is similar to the silicone method. We are going to be implementing this in two case studies, and so one of them will be looking at also biological exposure. So microbes is something we don't talk that much about, but they have an impact on our health that, you know, we're probably just scratching the surface of understanding how we interact with microbes. So in this case, we're going to do passive area sampling, just putting these kind of essentially dust collectors out in people's homes. and analyzed for microbial diversity. I do know somebody from the US who has actually carried around a sampler like for a year, and then sort of, I don't know if anybody's seen this, they've actually analyzed the microbial diversity in a few people. And actually, it's really interesting to see the differences you might get depending on where you travel and everything like that. This is also a man that wears 2 smartwatches. So. So the other thing we'll look at is we also have an environmental sensor. So this measures in real time. It's about the sensors, which talk about a little bit more. We also measure physical activity and heart rate in some of our participants. And then we try to use like a mobile app to ask people questions throughout their day so we can have a little bit more information and a little bit more contextual information about what they do, how they feel, that kind of thing. So yes, if you imagine being a participant in the study, you have to be quite dedicated. I'll focus on the environmental sensor today just because we only just started deploying these things. So that's the data that we have ready so far. So again, back to these low-cost sensors, you know, exposure scientists were really keen on them because you can sort of shrink down your measurement technology into something that's wearable, hopefully. Although it's, you know, when you wear this for a week, it's maybe not the most convenient thing. But this is the little sensor box that a company has developed for a project, and it's quite small, as you can see. It can be worn on any number of different places, and we've had some debates about this, especially because one of the things we measure is UV and also light. But the waist actually turns out to be most convenient for our participants. So you know, exposure studies are always a bit of trade-off between what you want to do scientifically and what you can actually get someone to do. So this little box will measure particulate matter, noise, light, UV, temperature, and humidity. So that's quite a lot of different things. Why those things? Some of it is, you know, usually PM and noise are things that are of interest in occupational environments. One of our case studies is shift work, so light is of interest in UV as well. The question, of course, is everybody wants to know how good are these sensors? So we do have a QA/QC protocol, but of course we did then compare these low-cost sensors with reference instruments, and we did this for calibration. We use a static monitoring. So, for example, we have a noise level, a sound level meter. We have kind of direct reading, as well as I think we've done some filter-based sampling for the particulate matter to do some calibration. Generally, most of the sensors seem to have a pretty linear relationship, so you can kind of easily correct for that. Particulate matter is more tricky because again, this is it's based on the reading is based on light scattering, and so the aerosol type will change how what the results you might get are. And we did find that in different occupational dusts can really change the results that you get compared to a reference instrument. So we're trying to think up a way that we can try to do this particulate calibration more easily, so that you wouldn't necessarily have to do an independent calibration in every setting you use the sensor in. As I mentioned, we're just rolling this out in some short-term studies where we ask participants to wear the sensor for about a week. I'm going to show a little bit of the sensor data that we get. This is just an example. We have some initial data from 12 participants in Denmark, and this is the temperature data from each participant. And you can say it's a direct reading instrument, so it does measure a fairly high frequency. I think every minute or every couple of minutes, I don't remember the exact frequency. This is just to illustrate for 2 different people. We smooth out the data a bit. You can see the trends in the data. So this is really nice because there was a question earlier, I think from Tim to David, about do we know much about whether you have peak exposures or really high exposures have different impacts from low exposures. And actually, this is something we've never really been able to study that much in epidemiology, because we always rely on like an average exposure for a certain amount of time. So this type of data might help us answer those questions. So I'll talk a little bit about kind of just give an example of some of the initial looks that we've had at the data. Again, this is very early, so I don't have anything very exciting and new to show, but this is again data from 12 participants, and you can see for particulate matter, this is PM 2.5. Everybody's got a different pattern, and their trends are different over time. So, we can look at these week-long trends in exposure, but we also want to be able to see what kind of differences there are between people. So as an example, we might explore the time of day, the impact of the time of day, the location of work. So in this case, we are just splitting people out in different categorizations. It's only 12 people, so we have male and female. And it was sort of interesting. So you look at across the population for males and females, what their average exposures would be across a 24-hour period. And then you see, oh, well, it seems like the males for some reason have higher exposures in the evening. What are they doing then? I don't know. So the other thing we can do is we want to know where did these occur? So using the UV sensor, we apportion people to being indoors or outdoors. So it seems that the higher exposures occur outdoors rather than indoors in this case. But then if we look a little bit more closely now, we split them out by occupation type. So most of these are more managerial workers. So we didn't really split it out by job, but we did look at self-employed versus employed. So the red is employed. So you're an employee of a company or something. And then the blue is you're self-employed. So now you see another pattern that actually seems like the self-employed people have higher exposures to PM 2.5, especially during the day. So we look again at the indoor and outdoor aspect, and then you can see actually that what I showed earlier is driven more by the people who were self-employed, and actually the people who were kind of employees had very similar exposures both indoors and outdoors. So this is kind of something that you can do with direct reading instruments that I think is very interesting, both for just kind of an exposure management perspective, but also you can start teasing out in your studies, more explanatory variables that might also help explain the impacts, the health impacts that you see. Just as a comparison, I'll use noise as just to show that there's, we've got another variable we can look at. And this one, you don't see as many differences between male and female. And, during the day, there's more noise in the exposure than in the evening, as you might expect. And the noise exposure tends to happen more outdoors. When we look again at self-employed versus employee, again, you don't see very big differences in either, whether it's indoor or outdoors or across the day. So this is just kind of an example of the type of analysis that we can do with this data. Obviously, I've just showed data about kind of the different patterns across the day and between people. How do we contextualize it? Well, we're using, some studies might use GPS, so you track people around and you say, okay, well, it seems like their exposures are higher when they're in the car or something like that. Instead of doing that, we're not using GPS, but we do have questionnaires, as I mentioned earlier. It's using, if you're familiar with this ecological momentary assessment method, where you have an app and it asks you at certain times a specific question. We've developed one that is specific to the two studies that we're doing, the respiratory health study and the shift work. So the questions will be for the shift work study related to the shifts, and they're also interested in, for example, when they take their meals relative to their shifts. We also ask in general about their anxiety and mood, sleep quality, and respiratory symptoms. So we can start to link that data with the exposure data that we get, because it is time-stamped to different parts of the day. So again, future analyses, we hope to get at least 300 people in each case study, but we're not sure if we'll manage to achieve that sample size, but this is will be really exciting if we could. We'd like to look at correlation between exposures, and this is just an example of a heat map of the initial the sensor data that we were looking at. We obviously have other data that we will have on chemical exposures, as I mentioned earlier, as well as biologicals and physical activity, etc. So we can look at correlation between exposures. We might look at some dimension reduction methods, if that makes sense in this case. We can evaluate the predictors of exposure, but we'd also like to use this data in health effect analysis. There is data, for example, in the respiratory health study of lung function across the day for the participants. Just as an example, this is nothing to do with workers because this is in children, but we have done similar analysis with another study that we've had in India. And we had the kids had a personal PM 2.5 monitors, but we also had monitors at home and at their schools. And so we would like to look at this, or we did look at this activity space, and we looked at kind of, what was better predictive of some of their health outcomes. And in this case, we looked at asthma control, which is a kind of, it's a score that you give an asthmatic, you ask them a certain set of questions and we do it repeatedly. We looked at this over time. So this is kind of the trends of each of the individual asthma control scores over time. So we wanted to look at whether their exposures predicted a decline in their asthma control score, implying that their asthma control worsened. And we did find that for every 10 microgram per meter cubed increase in the personal level PM 2.5 measurement, there was an 8% higher odds of being in a group of asthmatics which had worsening asthma control. Interestingly, we also looked at the indoor, at home, and school measurements, and actually the personal measurements did predict the outcomes better than the other two. So I think this is something where it would be really interesting if we could get more data. We talked about having a better database of indoor levels, but we also would be great to have another a database of kind of personal level exposures as well. So just a little bit about COVID. I know it seems like a strange jump, but there is a connection. So in this case, we did a study in hospitals in Scotland, just because this was during COVID. So obviously this is an area of great concern. And we really wanted to understand how, is there a way that we can also help predict the efficacy of different interventions? So we did so this is kind of back to sort of this approach, which I think is really interesting. When you look at exposure, really it's a combination of activity. So there's a personal and social aspect to it, as well as the environmental aspect. So we did both some environmental sampling and just did some records of worker activities, and we use this to model the potential risk or from exposure to SARS-CoV-2. I'm not going to go over this, but essentially environmental sampling, we looked briefly, we looked at COVID positive wards as well as non-COVID wards. They were called assessment wards, so it was unknown what the COVID status was of their patients. Something to remember is during COVID, a lot of hospitals repurposed normal wards, so they weren't really made for infectious disease control. And we did surface sampling, air sampling. And just some quick results. This is actually, we were interested in using this in modeling, so we created distribution of from the data. So it's a bit different than how studies would have presented their sampling results. And so I won't necessarily go through this in great detail, but these are the results from our 2 COVID wards. Oops, sorry. Animation's a bit off here. So the site features, something that I think is interesting and important to know, which I didn't know until I did this study because I'd never really worked in the hospital space before. So buildings were older, and a lot of them were designed before, the current health technical memorandum guidance for healthcare ventilation. So a lot of them didn't necessarily have mechanical ventilation, and we're talking mostly about the COVID wards as well as their non-COVID wards. And so we did find that the guidelines, the today guidelines, weren't necessarily met, which is not to say that, they were all not in, they were poorly controlled. It was just that when you think about it, they didn't have to meet these guidelines because that's not what they were designed to. We did find that some areas, where there was mechanical ventilation, they could have used some rebalancing to achieve their pressure cascade. So there's this aspect of maintenance of ventilation, which kind of came out as being something that perhaps needed a bit more attention. And interestingly, the thing I want to highlight here is really that we were surprised to find that there were relatively, that there were positive or suspect samples in areas we didn't necessarily expect them to be, which were waiting rooms. And I guess, you might expect them in PPE donning and doffing room. But patient areas we would have expected to find them in. Waiting areas, not so much. And these are areas where, again, there wasn't necessarily much ventilation going. Then there weren't windows necessarily in these areas, but there are areas where staff might spend time during their breaks, or visitors might be, although there weren't visitors during COVID, obviously. So this is something where, we sort of fed the data into this model. And so it's a quantitative microbial risk model. And essentially the idea here is what I'm trying to bring this together is, you do this environmental sampling, but you really need to be able to bring it together with some of the contact data. So how, and whether it's air pollution exposure or pathogen exposure, you really have to understand how people come into contact with these agents of risk. And the benefit of being able to do that is that actually you can explore the impacts of different interventions. And that's actually ultimately, I think, what we want to be able to do is say, okay, well, you've got these exposures, but how might you actually change them? So in this particular case, this is just a kind of a simplified results of if we were to look at wearing face masks or surgical masks, in this case, respirators instead of masks, or use other measures such as surface disinfection or air kind of cleaning systems. And I won't necessarily go over the results per se, because some of it is, to be honest, it's based on the assumptions that you put into the model, but it would appear in the perfect world that actually engineering solutions are good, which is not surprising. So if you can actually have better ventilation, or you have better localized exhaust ventilation around patients, that might actually have more benefit. Certainly wearing an FFP2 would be better than a face mask, even though a lot of clinical trials find that there's no clear evidence on that. And that's sort of an interesting aspect of observational studies and what they can and can't do. So this comes back to the sensors a little bit. So, based on the results of the findings, we think that maybe there's areas, the hospitals don't necessarily, they're mostly, some of the areas are naturally ventilated. They don't necessarily have indicators of how good their ventilation is. And so we thought, okay, everybody's been talking about CO2 monitors since COVID as an indicator of ventilation. They've been used in schools. And we know that certain areas are not really monitored. And so many people wouldn't necessarily know what their ventilation status is. So the question is, could we use things like CO2 monitors or other types of sensors in spaces to help people be more aware of what their ventilation situation are? And this is something perhaps we also want to focus on break areas or areas that people spend time in that are quote unquote non-work times and spaces. And this was brought up actually by the hospitals themselves, but also we did some work under COVID with food and drink processing facilities, and they all said, we think it's these areas, because we've controlled the workspaces quite well. And obviously, it's a bit convenient to say that, but that's not to say that that isn't true, actually. But these are important spaces because people may then let their guard down, take off their PPE in these areas, or they may not be, controls may not be as stringent in these areas. So I think there is room to use these types of sensors, but we sort of have to be careful about what the communication is around them in terms of how you can interpret the data, and then having data isn't really enough. It's really just what you do with that data. And I think that goes to, giving information when someone can't do anything about it. The question is that really useful? And I think that's it's a bit of an ethical question. It's something that was put to me actually in another proposal that I had, and I thought it was actually a really good point. So I think we really need to understand better how we use the data to the best effect. On that point of CO2 monitoring and what I just mentioned, it's interesting because I did find someone that did sort of an intervention study, and they didn't really find a big difference using CO2 monitoring during their monitoring and non-monitoring periods. Sorry, it's the intervention period. So what they did was they had a CO2 monitor, and staff were required to then, keep levels below 800 ppm by, doing various things like opening the windows, etc. They did identify a number of barriers to implementation, and so most of this is about cold for the patients or discomfort of patients, but other barriers as well. So I think it points to the importance of also kind of working with the system that you're in, so working with your staff, but also understanding what can and can't be done. And oftentimes, I think we see with interventions that there are unintended consequences simply because you didn't really maybe look at the whole system. So this is something which, again, with sensors, having used them quite a bit, there's also this danger a little bit of not completely accounting for what are the things that happen around the use of the sensor. And so I'm going to just kind of finish up by saying, bring it back to what I said at the beginning. We really want to understand how we can work for longer, because most of us will have to, especially given the current economy. But there are other things that we should consider in terms of kind of workplace health. And I think actually air quality has a lot to do with it. So, it's about how comfortable is your workplace. So it's not just about breathing in pollutants or not. And oftentimes you don't necessarily know, but how comfortable and how productive can you be at work? And I think air quality has a lot to do with that. So, and obviously for long-term health, even at relatively low levels of exposure to certain pollutants, it can have an impact. So, yes, and I do think that sensors are something that we can use more in this area to help manage exposures at work. I won't go through this because I realize that we're probably running out of time. But yeah, so I just, lots of help in the data in the studies that I've presented. So these are some of my collaborators and colleagues who have done a lot of the work that's gone into it. This is a project that I mentioned on the exposome. It's a European project, and I'm happy you can contact me later, or I can take questions now if there's time.
We can one question before. Go ahead, Mike.
I was really interested in all of your talk, but the very sort of preliminary results you showed, it was a wonderful illustration of sort of interpretation of data. So the finding that if you're self-employed, you get much greater PM exposure outdoors than if you're an employee. Is that just because self-employed people spend a lot more time outdoors, or? Well,
so I didn't want to go. So I don't have information yet, or somebody that has this information, but not me at this time, on what that. So that was one of the things that we looked at, and we saw that, and we're like, okay, let's go find out what was that job of that self-employed person, because it indicates that, yeah, maybe they were outside more during the day because they were self-employed, or maybe their job was something like they were a delivery worker, as an example. And that's maybe why they had higher PM exposures, because they're perhaps driving around. We don't know that yet, but I think that was a really interesting and unexpected finding. So I think what I was trying to more illustrate is that, it's like, was it Mark or someone who said this earlier? It's like a story that you can tell with this kind of data. And I find that really interesting that you can then like delve into it and try to understand better what's driving these exposures.